Hit the subscribe button or visit us at auau.auanet.org.
All right, wonderful. Thank you so much, Dr. Morgans, and to the entire team. So now we're going to continue to expand on this discussion around the use of chemotherapy, treatment sequencing, and the data behind that, and then how we think about future treatment options for these patients. And again, I think, as I mentioned to my group as well, that very much for the treatment of men with metastatic castration-resistant prostate cancer, it's not like it was 10 years ago. It's the chess game, not playing checkers when we only had docetaxel and mitoxantrone. We have so many new options, and it's even better if we used biomarker data from these patients to guide those recommendations. So when we think about summary and how we sequence to consider these different agents, this is a slide that, again, you've seen iterations of that throughout the day, so I won't spend too much on it. But really what it is asking, when do we give those more aggressive androgen receptor targeted therapies such as abiraterone, enzalutamide, darolutamide, or apalutamide? How do we sequence? Again, coming back to Dr. Morgan's really critical point, we never go from one AR therapy to another. Tolerability is better than some of those other agents, but the efficacy is near 0%. And I think all of my patients say, no, if I'm going to get a treatment, I want the best chance at getting something to work as possible. As mentioned, Sipuleucel-T, FDA approved for asymptomatic CRPC. We do not expect to see radiographic or PSA responses, and we don't want to spend too much time using a therapy that, again, may not be effective for those patients. And again, that duration of that improvement in survival really isn't until after 6 months of therapy. So again, we really want to, if we're going to use CYP-T, use it early in the disease course. In terms of who are those patients who may get better benefit? Again, use it early, because the majority of that benefit, when we look at the post hoc analyses, really seems to be for those patients with low PSAs. Again, and as you're seeing here. In terms of abiraterone, as mentioned earlier by Dr. Stratton, again, there are some potential comorbidities with abiraterone. Edema, fluid retention, hypertension, which can be associated with heart disease and other cardiac issues. Of the toxicities from prednisone, hyperglycemia and poor wound healing is on that list. But I got to tell you, when I'm giving prednisone at 5 milligrams or once a day or twice daily, the incidence of those issues, except for really brittle diabetic patients, is extremely low. So it's something that, generally speaking, does not influence my clinical practice. How about comorbidities with enzalutamide? History of seizures is a black box warning with enzalutamide. However, when we look at some of those original clinical trials with enzalutamide, we found that it was in a very low number of patients. In fact, only 4 patients. 3 of those had other reasons for having a seizure. At the same time, if you do have a patient who has a seizure history, you want to counsel them and have that discussion. In terms of optimal sequencing of abiraterone and enzalutamide, there were a couple of really critical trials to help us understand what's the clinical utility of going from one to the other. So this was a randomized trial that was performed at the Vancouver Prostate Center, published in Lancet Oncology in 2019, in which patients with metastatic CRPC were randomized for first-line treatment to abiraterone or enzalutamide. And at the time of progression, they were then switched to the alternative agent. So if you were on enzalutamide, you switch to abiraterone. If you're on Abi, you switch to enzalutamide. What we found in this particular clinical trial, however, was that switch, that transition, that the response rates, the PSA response rates, essentially that transition, there was no difference between group A and group B, but that switch, that the response rates were less than 5%, meaning, and that's PSA response rates or radiographic response rates. So other things that really tell us that if we're going to use one, when we have patients with CRPC, if they have not already seen that therapy for castration-sensitive disease, there's a number of good options that have not been, when we look at the head-to-head comparison, really no difference. But again, limited studies in that space. So we use toxicities. Really, for my patients, it's actually financial toxicity that is the biggest decision maker. And especially for my patients who are underinsured or uninsured, support groups are really critical for that, or support mechanisms are really critical for affordability. In terms of some CNS toxicities, there's a few other things that are listed here. Again, our clinical trials that were done, again, many years ago, did not do a great job of assessing depression or other CNS adverse events. Current trials are ongoing, led by Dr. Morgan's, I think are going to be the definitive trials to answer these questions. But again, it is something that I do ask all of my patients of, how are you? How is your mood with these new therapies that we're starting? Are you noticing anything in terms of memory changes, difficulties that are impacting your quality of life? Because we do have other treatments that can help mitigate those toxicities if they occur. So again, other things to be cautious and aware of. In terms of the sequencing question, as I mentioned before, that small studies indicated that the PSA declines and time to progression for patients going from one to the other is extremely short, showing essentially no response. Now, when we think about other therapies, here's the Alsimca trial looking at the use of radium-223, again, showing that whether patients have had docetaxel or not, that there is a significant improvement with regards to overall survival. But again, just remember, this was compared to placebo. So we do have other therapies now, more contemporary agents that, depending on the clinical context, may be of greater benefit. But again, for patients who have not had chemotherapy, that's certainly an option. In terms of using it before or after, one of the things that I'm really cautious and certainly counsel my patients on, that radium-223 is not effective against any soft tissue disease, lymph node, or certainly visceral disease. Patients who had lymph nodes smaller than 3 centimeters were allowed to enroll in this trial. But again, that's something where we really have to be cautious if somebody's having other symptoms, especially from large retroperitoneal or pelvic adenopathy, that over the course of time, new symptoms could develop or could get worse. In terms of the use of docetaxel, and again, so this is the SWOG 9916 trial as well as the TAX327 trial. One thing I'll caution folks is to recall that these patients and eligibility required patients have symptoms from their disease. So patients who are asymptomatic or minimally symptomatic, that's really when I think about some of those other options that we've discussed today. But certainly for someone who has symptomatic CRPC, docetaxel is FDA approved and does show a survival benefit. So who would I think about for docetaxel? As mentioned, criteria number 1, symptomatic mCRPC. Visceral disease, especially liver metastases. Now, this is also, as we've talked about, the importance of getting diagnostic information to determine if patients are developing or evolving more of a neuroendocrine or small cell carcinoma, and also making sure that we're sending those tissue biopsies off for genetic testing to identify, for example, if a patient has a high tumor mutation burden, it could be a candidate for pembrolizumab, or a BRCA2 mutation with olaparib or rucaparib as treatment options. But again, we won't know unless we do the sequencing. So some other indications as you're looking at docetaxel, that's also the time to make sure that you've got tissue that you can send for genetic testing. Some great discussions in my group around the role of liquid biopsies for sequencing, including the strengths as an accessible tumor source, but also the limitations, especially for patients who are responding to therapy. Some of those commercial liquid biopsy tests aren't very good at detecting BRCA2 deletions. Great for point mutations, but they can miss a significant number of patients who have a BRCA2 deletion. We also worry about clonal hematopoiesis, essentially false positive mutation calls, again, that should not impact patient care. What about cabazitaxel? So as you see here, the molecular structure of cabazitaxel is very close to docetaxel. However, preclinical studies showed that it may be able to overcome resistance to taxane chemotherapies. Clinical trial that was done that led to its FDA approval was the TROPIC trial, showing that cabazitaxel was significantly better than mitoxantrone in patients with mCRPC that had progressed on docetaxel. Adverse events to be careful of, again, similar to most taxanes, but the one that we have to be very cautious of is neutropenia and febrile neutropenia. Much higher incidence than we've seen in other taxane-based chemotherapies. And there was an increased risk of death for patients who did have neutropenia on this agent. So something that we absolutely have to be cautious of, and every patient is required to have G-CSF prophylaxis to prevent neutropenia, again, because of that risk of death. There was one study asking, the initial TROPIC trial used cabazitaxel at 25 milligrams per meter squared, which was actually higher than the recommended phase 2 dose from the phase 1 trial with cabazitaxel. So they did another trial asking, well, what about 20 milligrams per meter squared? Could that be better tolerated but still maintain efficacy? And that's essentially what you're seeing here in the Procelica trial, showing that cabazitaxel at 20 milligrams per meter squared was essentially equivalent. So now that is the recommended dose moving forward for patients with metastatic prostate cancer. Again, risk of neutropenia still persists. So again, febrile neutropenia was much lower at 20 milligrams per meter squared than 25. Now, this next trial was the CARD trial, and one of my favorite papers from 2019, and something that's really worth time because it was one of the first paper that really addressed this question of sequencing. So what this trial did is it enrolled patients who had progressed on a second-line AR inhibitor. So patients who or second-generation AR inhibitor. So if you were on abiraterone or enzalutamide, you were eligible for this particular trial. One caveat is that it required patients who had progressed on this therapy in less than 1 year. So again, a very high-risk patient population. Different than that patient who has been on abiraterone going on 3, 4, 5, or 6 years. But the CARD trial took that higher risk patient population and randomized them. If you were on abiraterone, you were randomized to get enzalutamide or to get cabazitaxel chemotherapy. Enzalutamide, you were randomized to abiraterone or cabazitaxel. What they showed was really profound, that there was a significant improvement in radiographic progression-free survival of 8 months versus 3.7 months by getting cabazitaxel chemotherapy. So again, confirming that those mechanisms of resistance, again, cross-resistance is a real critical issue. And it's important that patients receive or switch to another mechanism of resistance or mechanism of action, as Dr. Morgan said. And this also held out for overall survival as well. As mentioned earlier, it's always critical for patients with CRPC to ask, is it still an adenocarcinoma, especially in the situation of liver metastases or bulky lymph nodes, or a low PSA in the setting of a very high volume disease or a lytic disease as well. Biopsy and metastatic site, especially if soft tissue is always preferred for genetic testing. We actually do a lot of bone biopsies at my institution. Most of my patients have very few side effects. They feel like they've got a bruise that goes away after a couple of days. For us, the critical issues to improve our success rate was to use CT guidance for that biopsy and to collect frozen cores. Do not allow the pathologist to do a decalcification. So with that approach, our success rate for bone biopsies is over 85% now. And that can be used for any kind of molecular testing. The things we're looking for are neuroendocrine or small cell prostate cancer differentiation, a disease that is not responsive to any AR manipulation, and we're thinking about chemotherapy and potentially even platinum doublets as well. As mentioned multiple times, and again, this is why we keep pushing this, is that it's so critical to evaluate for genomic mutations. Some of the latest data that's coming out indicates that for patients with metastatic CRPC, less than 50% ever have molecular testing performed. That means that there's a significant portion of patients that are not getting appropriate therapy. We've already talked about BRCA2 and other HRD-related mutations. And again, this concept of synthetic lethality on why PARP inhibitors do sensitize these cancers to cell death. You've already seen data in terms of the utility of olaparib for patients who have defects in DNA repair genes, with the majority of that benefit being for patients with BRCA2 mutant prostate cancers. I'm going to move quickly through the PROfound trial, again, because we've already had a chance to discuss that with Dr. Morgans, and again, why this is such an important therapeutic agent. I will add just one thing, as mentioned, there were multiple other genes from preclinical studies suggesting association with HRD. But again, it appears that the majority of the benefit is for patients with BRCA2 mutations. It's something I talk about for my patients who have these other mutations, but things like ATM, more recent studies have suggested that there's really minimal clinical benefit for the patients in that situation. Eligibility for pembrolizumab. It's not common, but gosh, when you see it, there can be profound benefits. Again, anywhere from 2 to 4% of patients may have mismatch repair alterations or high tumor mutation burden, and we can see really dramatic responses. And you'll read about case reports for patients who are years with disease-free for many years with treatments with pembrolizumab in this clinical situation. Here's some of the early data in terms of PSMA lutetium, as has been mentioned before. Some of the early data indicated that we could get PSA responses in the vast majority of patients who had mCRPC, in which all sites of disease were positive for PSMA. And that's a really important caveat as we look at what's been done with some of the other clinical trials. Now, again, as we look at this waterfall plot where 99 patients were treated with a PSMA-based radioligand therapy, again, a significant portion of patients meet that PSA 50 response, though there's certainly patients that do not. In terms of side effects, again, dry mouth is one of the more common ones, especially because PSMA is expressed in the salivary glands. And there's important consideration, especially as a grade 1 dry mouth actually means that patients need to drink liquid just to swallow their food. So it really is a significant adverse event that we do need to talk about patients, especially for patients who have years of life ahead of them. So the VISION trial, as mentioned before, was a randomized phase 3 trial for patients who'd progressed on prior chemotherapy and one AR-targeted agent, such as abiraterone or enzalutamide. Patients were randomized to receive that agent versus the standard of care therapy. Because of time issues, I'm going to skip a little bit of the details, but I did want to point out that patients were required to have all sites of disease positive for PSMA, of which the vast majority did. Around 90% of patients were positive and eligible for randomization on this trial. What we found was that they did meet their primary endpoint in terms of, as you see, a 4-month improvement in survival, 15.3 versus 11.3 months. So this is, again, meets what we've seen with other agents in this particular context. We also saw the rPFS endpoint of 8.7 versus 3.4 months in this trial. Again, a significant improvement in these clinical parameters. Maybe not as good as we had hoped, though, especially for patients who had all sites of disease positive for PSMA based on the criteria that were set. In terms of adverse events, we've had a chance to talk about fatigue, stomatitis, as well as bone marrow suppression. Again, still, though, generally a well-tolerated radiopharmaceutical or radioligand therapy. So kind of summing up, again, I know I've thrown a lot of data today at you so far, and hopefully this echoes some of what you've already heard. But we have multiple therapies for patients with metastatic CRPC. There's multiple clinical parameters that we need to take into consideration. What are the sites of disease? Is there soft tissue or visceral involvement? What prior therapies has a patient been exposed to? And what molecular information do we have to guide our patients to the appropriate therapy? So kind of summing things up, if you're thinking about using CYP-T, use it early. Use it in patients with low PSAs and patients who you're not looking for a disease response. In terms of how do we sequence multiple AR receptor targeted therapies, again, they're FDA approved with relatively low toxicity, but the efficacy, if you go from one right to the next, is almost 0%. So really, this is critical to look for other agents with other mechanisms of action, though we may at some point in time in the future go back and try an AR-targeted therapy. Radium-223, certainly an option for patients with bone-only metastases, and especially if we may not be looking for docetaxel for someone who has minimally symptomatic or symptomatic disease. Pluvicto or PSMA 617 or PSMA lutetium. Again, there's lots of names for it here that you'll hear, names that you'll hear. It is FDA approved. It does require a PSMA PET for eligibility, and it's only after patients who've had one AR inhibitor and a taxane chemotherapy. Clinical trials are ongoing, asking for patients, how well is it going to be effective before taxane chemotherapy? It's something I refer all of my patients to those trials if they're eligible. The sooner we finish accrual, the sooner we'll have an answer. Cabazitaxel, dose at 20 milligrams per meter squared, not 25, is also an appropriate FDA-approved agent. And germline somatic testing, again, I know I keep beating that drum. Everyone needs to have it done. If you do see that this is a cancer that's transitioned from adeno to a neuroendocrine or a small cell, platinum doublets should be considered, or if someone has homologous recombination deficiency as well. Future strategies, I'm incredibly optimistic. I'm a medical oncologist, so hope springs eternal. We've seen so much progress in the last 5 years and even in the last year alone. I'm incredibly optimistic for other options coming in the future. new combination therapies, new bispecific antibodies or antibody drug conjugates. There's so many new options. So our hope and our expectation is this will continue to grow in terms of what we have in our toolbox to treat patients with metastatic CRPC.